Welcome to Pharmacogenomics webinar on optimized medication outcomes through pharmacogenomics. Part 1, Basic Concepts. My name is Adrian Vilalta. I am the Vice President of Genetics here at Pathway. Today we'll try to answer a few questions related to pharmacogenomics, starting with why do we need pharmacogenomics in the first place? We'll touch on some basic pharmacology concepts. We'll discuss drug metabolism and action through pharmacokinetics and pharmacodynamics. We'll start the discussion on pharmacogenomics and some basic concepts around it. And we'll conclude by discussing the genetics and drug outcomes, some examples coming from the area of pain medication, mental health, and as well as cardiology. So why pharmacogenomics? So there are well-documented differences in individual response to medications. It is actually believed that up to 95% of those differences are due to genetics. So it is clear that as far as drug treatment is concerned, one size does not fit all. Because of this, pharmacogenomics is an essential component of the strategy to achieving personalized medicine. There are 4 high-level stages in drug disposition, namely absorption, distribution, metabolism, excretion, or ADME for short. All of these stages play a role in the efficacy of a medication. Today, I will emphasize the contribution of metabolism to the ultimate effect of a drug. Let's get started by going over a few key concepts in pharmacology, that is, the branch of medicine concerned with drug action. The first one is pharmacokinetics. So pharmacokinetics is defined as the branch of pharmacology dedicated to determining the fate of substances administered externally to a living organism. In short, what the body does to the drug. Pharmacodynamics, on the other hand, is the study of the biochemical and physiological effects of drugs on the body, the mechanisms of drug action, and the relationship between drug concentration and effect. In short, what the drug does to the body. I'd like to spend a few minutes explaining some basic pharmacokinetic terminology. This figure describes the circulating concentration of a drug over time. In this example, the drug is administered at time 0. After time Tmax, the concentration of the drug reaches a maximum denoted as Cmax. After this point, concentration of the drug decreases steadily over time. The time required to reduce the concentration of the drug by 1/2, that is T sub-index 1/2, or half-life. Exposure of the patient to the drug is represented by the area under the curve, or AUC for short. In this example, the drug is re-administered every 24 hours. That's represented by the Greek letter tau. A key point is that, ideally, a stable average concentration of the drug is reached under this regimen. The cytochrome P450, or CYP, group of enzymes is a key player in the metabolism of drugs. The CYP superfamily is one of the most important groups of enzymes involved in the oxidation of therapeutic drugs, xenobiotics, and endogenous compounds. Although CYPs are expressed in many tissues, most of the CYP-dependent drug metabolism takes place in the liver. The CYP enzymes in humans are encoded by approximately 57 genes. A specific CYP is described by standard nomenclature divided into families, subfamilies, and polypeptides, as in this example for CYP2D6. The CYP enzymes and the genes encoding them are designated with the abbreviation CYP or CYP, followed by a number indicating the gene family, a capital letter indicating the subfamily, and another numeral for the individual gene. Alleles are identified by CYP gene name, followed by an asterisk, and a specific allele name denoted by Arabic numerals. This pie chart on the right summarizes the relative contribution of each CYP to the metabolism of drugs. The following tables are intended to illustrate the wide variety of drugs and drug classes metabolized by CYP enzymes. For example, we have non-steroidal anti-inflammatories, we have beta blockers and other medications prescribed for the management of blood pressure. We have proton pump inhibitors, we have antidepressants, we have analgesics. All kinds of drugs are metabolized by CYPs. In addition to being metabolized, drugs can also have an effect on the levels of specific CYPs, as illustrated here. An important point is that not only commercial medications can have an influence on the activity of CYPs, one also has to consider the potential effect of traditional remedies and even some foods. Importantly, drugs can also inhibit the activity of CYPs. This is an important consideration while evaluating potential drug-drug interactions. We have now briefly discussed some pharmacokinetic concepts and key enzymes important in the metabolism of drugs. Let's now briefly touch on pharmacodynamics. As we stated before, pharmacodynamics relates to what the drug does to the body. These effects are mediated through protein receptors, many of them membrane-bound. Let's use the mu-opioid receptor as an example. This slide depicts the protein structure of the mouse mu-opioid receptor bound to a morphine analog, also called an agonist. As is evident from the space-filling model, the interaction of the morphine analog is very tight and specific. This type of interaction is not surprisingly often referred to as lock and key. Importantly, as the agonist binds to the receptor, it triggers conformational changes in the protein that then initiate a cascade that leads to the ultimate effect of the drug. This cartoon represents the binding of a drug to its receptor. The binding triggers the drug effect. However, if the drug does not bind to the receptor because of the lack of a good fit, then no effect is observed. On the other hand, if the binding site is blocked by an inhibitor, then the effect is either reduced or eliminated. Interestingly, this change in affinity for the drug can also be observed in protein variants that change the size, charge density, or other key characteristic of the receptor binding site. With all these concepts in mind, now we are ready to discuss the effect of genetics on the patient's response to drugs. Let's start by reminding ourselves that human DNA contains many sequence differences between individuals. Most of these differences do not have any functional significance. However, variations that alter the activity of a drug or drug receptors are central to the field of pharmacogenomics. Let's use the genetics of CYP2D6 as an example. CYP2D6 is not inducible. The variability in CYP2D6 enzyme activity is mainly due to genetic polymorphisms. CYP2D6 shows the largest phenotypical variability among all the CYPs, thus making it a great example. Variants in the CYP2D6 gene that result in differential activity of the enzyme are well documented. The table on the right summarizes some of this information. First off, CYP2D6*1 on the top is the wild type, normal function version of the gene or allele. On the other hand, we have some of the variants, for example, CYP2D6*4, that abolish the enzyme activity. CYP2D6*9, on the other hand, shows decreased activity. Now, how does all of this translate into enzyme function levels in a patient? First off, there are 2 copies of these genes, gene loci, in the human genome. Each one of these 2 copies might be the same or slightly different. For example, we could have 2 gene copies coding for a wild-type allele or any other potential combination. The table on the right summarizes this concept. Patients that are classified based on the allele combination and the predicted effect on enzyme activity. Thus, a patient with 2 non-functional copies of CYP2D6 is classified as a poor metabolizer, or PM for short. In the same fashion, an intermediate metabolizer, or IM, will have either 1 non-functional allele and 1 reduced functional allele, or 2 reduced functional alleles. Extensive metabolizers will have 1 or 2 normal functional copies of the CYP2D6, while on the other hand, ultra-rapid metabolizers will have 3 or more normal function copies of CYP2D6. Importantly, there are well-documented differences in the proportion of each of these metabolizer statuses along ethnic lines. In this example for CYP2D6, we see a clear difference between the proportion of poor metabolizers in African Americans, about 2 to 8%, compared to, say, East Asians, which are under 2%. Caucasians and Hispanics are somewhere in between. Intermediate metabolizers also show some clear differences, East Asians being about 50 or 60% intermediate metabolizers. For ultra metabolizers, jumping to the last line, East Asians are under 1%, while Caucasians are between 3 and 10%. Having said that, consideration of a patient's ethnicity is no substitute for genetic testing given the reported difference intervals. These are a couple of examples highlighting the effect of metabolizer status on enzyme activity and effective dosing. Let's discuss bufuranol first. This drug is a potent beta blocker. The graph depicts the observed hydroxylation activity for patients of each of the CYP2D6 metabolizer statuses plotted against the relative frequency of patients in each category. Clearly, there is a wide spread of activity across PMs through ultrametabolizers. Now, how does this translate into effective dosing? Let's use nortriptyline, a second-generation tricyclic antidepressant. As indicated in the figure, the population-based dosing would be most effective on EMs. However, PM, IM, and UM patients might not respond at this dose, or even worse, they may display severe adverse events. So what is the effect on AUC? So the graph here shows you a simplified version of the graph that we discussed when we introduced some of the pharmacokinetic concepts. Again, ideally, you administer a drug, it reaches a maximum, it decreases steadily over time, and then you redose and maintain then a stable concentration of the drug in the system. However, conceptually, you could have people who are poor metabolizers that do not clear that drug efficiently enough. So the concentration in plasma might increase steadily as you re-administer the drug and potentially create some adverse event in these patients. Now, let's start our discussion on specific medications and the pharmacokinetics, pharmacodynamics, and of course pharmacogenetics associated with this. Let's start with codeine. Codeine is the second most predominant alkaloid in opium. Opium being one of the oldest medications used by mankind. Some say that they predate history. Opium is the latex from the poppy, the plant being called Papaver somniferum. Codeine is an opiate commonly prescribed for its properties as an analgesic, stimulant, antitussive, antihypertensive, sedative, and hypnotic. Codeine is also sold as a single ingredient or a co-formulation with other medications such as Tylenol, ibuprofen, and aspirin. The principal pathways for metabolism of codeine occur in the liver, although some metabolism occurs in the intestine and brain. Approximately 50 to 70% of codeine is converted to codeine 6-glucuronide by UGT2B7, as indicated in the slide. Codeine 6-glucuronide has a similar affinity to the receptor as codeine for the mu receptor. Approximately 10 to 15% of codeine is demethylated to norcodeine by CYP3A4, again indicated in the top part of the slide. Norcodeine also has a similar affinity for the mu opioid receptor as codeine itself. Now, between 5 to 10% of codeine is all demethylated to morphine, the most active metabolite. However, morphine has about 200-fold greater affinity for the mu opioid receptor compared to either codeine, norcodeine, or codeine 6-glucuronide. Therefore, the main contributor to the efficacy of codeine as an analgesic is CYP2D6. This is then captured in the FDA label for codeine. Just to remind you, the metabolized status for CYP2D6 is indicated on the left, and again, that has to do with a combination of alleles in the patient. It's very well documented that PMs may experience little or no pain relief from codeine. Ultrametabolizers are at a high risk of severe toxicity, on the other hand, and may experience adverse reactions such as respiratory depression, respiratory arrest, shock, and/or cardiac arrest. Infants who are breastfed by mothers who are ultrametabolizers and taking codeine are also at an increased risk for morphine overdose. Let's switch to clopidogrel, commonly known as Plavix. Plavix is a widely prescribed blood thinner anticoagulant used to prevent or help prevent stroke, heart attack, treat patients with unstable angina, and PAD or peripheral artery disease. So let's discuss the metabolism of Plavix a little bit. The first step in its metabolism is an oxidation mediated by CYP2C19, as indicated in the slide. The resulting structure is a tautomer with another structure indicated there, so they are in tautomeric equilibrium. The second tautomer is then activated into the active metabolite, shown on the top right. Several recent landmark studies have proven the importance of CYP2C19 genotype in treating people with clopidogrel. In March 2010, the FDA put a black box warning on Plavix to make patients and healthcare providers aware that CYP2C19 poor metabolizers, which are about up to 14% of patients, are at a high risk of treatment failure. That testing is available. Now, the active metabolite, which is this one shown on the top right, has a thiol group that is known to irreversibly bind to P2Y12 receptor in platelets. It's this binding that inactivates the receptor and triggers the antiplatelet coagulation response. Here are some clinical data on the effect of CYP2C19 metabolized status on AUC. This is coming out of study in the New England Journal of Medicine, as indicated. The left two panels indicate the response on AUC and connected to the genotype of the patient. Two loading doses of the drug, 300 and 600 milligrams. Clearly, poor metabolizers have a reduced AUC compared to ultra metabolizers. This is still the case when you look at the last panel on the right, which represents the response to a maintenance drug of 75 milligrams. Now, what about the final clinical effect? Well, it's clear from this graph from the same paper that those patients that carry a non-functional copy of CYP2C19 are at a higher risk for thrombotic events, as indicated by the red line on the graph. So in summary, PMs are at high risk of treatment failure, and this is captured in the FDA black box warning. PMs have lower levels of the active metabolite, less inhibition of platelets, and an approximately 3.5 times greater risk of major adverse cardiovascular events such as death, heart attack, and stroke. Now let's discuss citalopram, also known as Alexa and Cipramil. This is a medication prescribed for mental health applications. So it's used to treat major depression, panic disorder, anxiety, obsessive compulsive disorder. Citalopram is a racemic mixture of R-citalopram and escitalopram. Citalopram is a selective serotonin reuptake inhibitor, or SSRI. Its main function is it inhibits the reuptake of serotonin at the synapse, therefore increasing the effective dose, effective concentration rather, of serotonin in the synapse. There are both pharmacokinetic and pharmacodynamic effects that need to be considered. The first one is that CYP2C19 PMs have impaired citalopram metabolism and decreased clearance. PMs are at an increased risk of citalopram accumulation and drug-associated toxicity, therefore. On the other hand, ultrametabolizers have lower citalopram plasma concentrations and increased risk of non-response. For pharmacodynamics, the serotonin receptor, HTR2A, mutations in it are associated with response to citalopram. As indicated in the slide, there are genetic markers associated with increased response or lower response. This is specific SNP. Those patients that are homozygous for the A allele, 79.9% of them are classified as responders, compared to 63.5% of white patients homozygous for the G allele. In other words, the homozygous A genotype for this SNP conferred a 16 to 18% reduction in absolute risk of being a non-responder in this cohort. At this point, I would like to remind the audience that Pharmacogenomics offers many reports that include pharmacogenomic testing in them, more notably mental health, pain medication DNA Insight, cardiac DNA Insight, and medication DNA Insight. In summary, we've discussed that there are many differences in inter-individual drug responses, and that this is an important consideration in the clinic. That is, one size does not fit all. Genetics can explain many of these differences. Genetics can explain differences in both drug pharmacokinetics as well as pharmacodynamics, giving rise to the field of pharmacogenomics. Genetic testing can help clinicians tailor drug treatment for their patients, thus helping enable personalized drug treatment. At this point, I would like to thank all of you in behalf of all of Pathway Genomics. If you have any questions, please visit our website, www.pathway.com. Please provide us some feedback on this webinar using the link shown on the screen at SurveyMonkey. If you have any questions about this presentation or any questions about any of Pathway Genomics tests, please send an email to research@pathway.com. Thank you very much for your attention, and we'll wait for your feedback.